That I would like to go ahead and introduce a longtime friend of mine, Dr. Reylon Meeks. Dr. Meeks is an RN who currently works as a consultant pediatric subject matter expert for the American Heart Association. She's worked on the pediatric advanced life support and PAIRS curriculums, authoring chapters and scenarios for both. She continues to teach in the hospital setting, providing education for physicians, residents, and nursing staff. She served on the Pleasant Hill Fire Department for 22 years, the last 10 as a chief, and she is recognized as the first female fire chief in the state of Iowa. Reylon was named the American Red Cross Hero of the Heartlands in the fire division and was one of 100 great Iowa nurses. Reylon currently sits on the County Board of Health and was appointed to the Governor's Committee on Interoperability for Iowa. Reylon holds a bachelor's and master's degree in nursing, master's degree in education, and her PhD dissertation titled Parent Presence in Pediatric Trauma Resuscitation. Reylon is also an EMS provider. She has worked her way up through that. That's where I actually first got to meet Reylon. Reylon used to teach a lot of my pediatric programs for me back in the day, and it is with pleasure that I introduce to you Reylon Meeks for tonight's presentation. Reylon?
Thanks, Steve. We're going to talk a little bit about pediatric trauma from tots to teens. And these are all actual case studies and lessons that I've kind of learned throughout the years that I'm just taking a moment to share with all of you. We're going to look a little bit about the differences between adult and pediatric trauma. Talk about the pediatric assessment triangle and how that actually works in the trauma setting. And then we're also going to take a look at some patterns of injury that are very specific to the pediatric trauma population. We know that pediatric trauma is the #1 cause of death and disability over the age of 1 year. Less than 1 year, it still remains SIDS. The interesting thing is, even though we've come up with trauma centers, we really haven't seen too much reduction in death due to injury in the peds population. And there's a couple of reasons we think that that's happening. And one of them is that we don't necessarily recognize that children are in trouble because they compensate for a very long time. The other thing is that we're not very good about airway management. And we think that probably that would be helpful in some of our lessons and teachings if we went over more of the pediatric airway and what we can do to help with that. 75% of deaths are unintentional in pediatrics. Motor vehicle unfortunately are intentional. These are our violent kinds of things with homicides and basically guns and kids killing each other. It's kind of a sad commentary, but it happened. The interesting thing is it doesn't matter whether the child has an injury or an illness, the pediatric assessment triangle is going to help you identify which of these kids are physiologically unstable, and those are the ones that you need to get to right away. There's really just 3 components to that pediatric triangle. It's appearance, work of breathing, and circulation. And the idea is that when you're walking up to a child, that you begin to with your first step, you look at what they look like. What is their appearance? Are they interactive with their environment? Are they inconsolable?
Reylon, we're having a little difficulty with your audio.
It's going too fast?
No, there we just
got you.
Yep, there we go. Yep.
Is it okay now?
Yep.
It's good.
Okay. Is the work of breathing, when we talk about that, we're not really talking about respiratory rate, but rather we're talking about the things that you can see on the child. Are they having retractions? Are they tracheal tugging? Are they nasal flaring? Can you actually hear them breathing? Is it high pitched? Is it low pitched? Are they grunting? Those are all signs that the child might be in trouble from a respiratory standpoint. And then lastly, as you get up to the child, you want to take a look at what their circulation is like. Are they pink? Are they perfusing? Are they blue? Are they mottled? Are they gray? There's all kinds of indicators that there's something going on. Regardless of that pediatric assessment triangle, whether it's an injury or an illness, it can help you when you just, as I say, walk up to that child. We'll talk a little bit about the primary survey. You're going to do treatments and outcomes, and then some pediatric patterns of injury as we go through these case studies. The first one is actually a 5-year-old. This was a little gal that she was on her big wheel and she rolled right out into the street in front of a vehicle, and she was brought in by ambulance. When we looked at her pediatric assessment triangle as she originally presented to EMS, she was really slow to respond. Her breathing seemed to be somewhat normal, but her circulation was really pale. And she just looked really off. Her airway on the primary survey was actually patent. Her breathing was normal with a rate of 24, but her cap refill was really delayed. And when we talk about capillary refill, we're really talking about when you lift the extremity above the heart and then check capillary refill. That's the correct way to do that. It's not pinching a finger when it's laying on a gurney at the same level as the heart. Her original Glasgow Coma scale was 13, so it actually wasn't too bad. When we actually did exposure on her, we noticed there's some ecchymotic areas on her chest. There was bruising in the right lower abdomen, and her right femur was angulated and quite swollen. And so, we knew we had probably a long bone fracture there. We probably had some internal bleeding with the bruising on that lower abdomen. And it was really difficult to tell what the chest was going to be like. EMS did a great job treating. They put her on 15 liters by non-rebreather. They put her on a long blackboard with a C-collar. She had an IV of normal saline running at a TKO rate initially, and then they went ahead and splinted her leg. The outcome on this kiddo was she went to surgery for a femur fracture. Her concussion resolved in about 48 hours, and she was discharged 3 days later. So she had a really good outcome, even though she ran into a car. The question is, what kind of trio is this injury? Are these injuries known as? And this is really what we call Waddell's triad. It's a real predictable pattern of injury with motor vehicle crashes. And I shouldn't say motor vehicle crashes, with pedestrian versus motor vehicle. And usually what happens, and usually this is when kids dart out in front of cars. What happens is most adults will, when they get hit by a car, they will go up and over the car. Kids will go down and under because their center of gravity is so much lower than that of an adult. They're shorter. As they get hit by that vehicle, the other thing that they do is they have a tendency to turn into the vehicle instead of away from. Again, another big pediatric difference with kids and adults. As they turn into that vehicle, the first thing that happens is they get thrown. Their head will hit the concrete as they
the audience.
I'm picking up some background and noise there. Anyway, their head will hit the ground. The extremities kind of fly out. In this particular instance, you notice that she had a femur fracture out of it. And then the trunk gets hit because that's where the bumper lands. So you can kind of predict that you're going to have all three of those when you have a child versus motor vehicle. There were about 4,444 pediatric trauma patients that were actually looked at. This was, it's been almost 20 some years ago now, but they looked at pedestrian versus motor vehicle crash. And as you can see, there were a number that had that head injury. Some had heads, some had legs, and some had all three. So there was kind of a question about, is this really a myth or not? But it truly is out there. And it would be something that I would look at whenever you've got child pedestrian versus motor vehicle. The warning signs with Waddell's triad too is if you have one or two of those signs present, you always want to look for that third one, because there can be a large amount of blood loss in internal cavities and spaces. The other piece of this that is kind of interesting is children will have blunt trauma 83% of the time. They'll only have a gaping open wound about 17% of the time. So there are huge differences in the adult population versus kids. So you have to be really suspicious that they probably have internal injuries versus what they actually show externally. The pediatric pro that I went with when this one was expect the unexpected. This was a 5-year-old, and when we actually got her into the trauma bay, she looked more like she was about 14. She was about halfway grown already. She had what we called precocious puberty, and so all of the stuff that we had gotten out in terms of sizes of IV catheters, NGs, Foleys. Everything was for a regular sized 5-year-old. Shoot, this kid was a teenager almost in her stature. And so it was very, very different in terms of what we expected out of her. So expect the unexpected. That's one of those pearls that always comes through. Our second was a little guy. He was 4 years old. He was a restrained front seat passenger. And what had happened was he and his mom were in a motor vehicle crash. The front end of their vehicle collided with a telephone pole, and the vehicle actually, the engine wrapped right around the pole itself. So there was quite a bit of, there was a lot of damage, and there was a lot of intrusion into the passenger compartment of about 14 to 16 inches. Interestingly enough, the mom was brought in as a trauma alert. So she got the full 90 yards in terms of she was C-collared, she was backboarded, she had IVs, she had everything that you would anticipate for a trauma patient. The child, on the other hand, was carried in on the hip of a paramedic. There was no long backboard, there was no C-collar, there was nothing. And when the child was handed off, the individual said, "Oh, I don't think there's anything wrong with this kid." When we looked at the pediatric assessment triangle for this particular child, the kid was not talking. His breathing was very shallow and he was incredibly pale. Now, this was a dark pigmented child. And so what we were looking at were the palms of his hands, the bottoms of his feet, and his lips were just virtually white, which was it was kind of terrifying to me. I really had not seen a kid that looked that bad for a long time. While his airway is patent, his breathing was a respiratory rate of 36 and it was really shallow. Cap refill was greater than 6 seconds. He had a heart rate of 180 and his radial pulse was faint, although his central pulse was okay. That right there told me a lot that number one, we had some kind of a shock going because of the prolonged cap refill. And the other thing is with heart rates, you can kind of figure 20 beats above baseline, and a 4-year-old would probably normally have a heart rate of 110 to, oh, I don't know, 115 or 120. This kid's running 180 and he's quiet. He's not crying, he's not talking, and yet he's running a rate of 180. That's 60 beats above what his baseline should be, or about, I was figuring, a 30% volume loss. That's a lot for a child. He was not interacting with us. He was lying in a fetal position and clinging to the nursing staff. Now, you and I both know that most 4-year-olds are active. They're running around like crazy, and they have a tendency to not pay a bit of attention to anything that's going on around them. And they're and they're getting into everything and looking into everything. This child wasn't, which is highly unusual behavior. We didn't see a lot of significant injuries other than his lips were pale and his palms were white. But we really didn't see like a seat belt or child safety restraint or anything along those lines that we should have seen across his chest. He was a trauma alert in the emergency department. We immediately started 2 large bore IVs and we had him out of the emergency department and into surgery within 12 minutes because we knew how critical this particular child was. What had happened was the child was not in a car seat at 4 years old. He was in the front seat and he was secured by a lap belt. And his hemoglobin at that time was 6.4. It should have been more in the 13 to 14 region. And so they, when they operated, they went in, they ended up moving a portion of his bowel. They removed his gallbladder. They took out a kidney because the one that had volced off of the renal artery was not viable anymore. They removed his spleen, and then while they were in there, they went ahead and removed the appendix just because they were there, so that he wouldn't have to potentially go back into surgery at another point in time. So, again, what is the common term for this type of injury? Because the child was seat belted in and not in a car safety seat. It's called lap belt complex. And it's sustained when a child's only restrained by a lap belt. What happens is they have a sudden rise in intra-abdominal pressure. It can rupture the bowel and cause injury to the lumbar spine. In this particular instance, even though the kidneys are free floating in a child until about the age of 7, when they kind of secure themselves down, there was enough G-forces that it actually tore that kidney right off of the renal artery. We were real lucky with this kid. He actually survived this event. The mistake that I learned, and one of the things that I will share is, I asked if the child was restrained in the vehicle, and they said yes. My vision of a 4-year-old being restrained in a vehicle is in a child safety seat in the middle of the back seat with potentially as anywhere from a 5-point harness at the minimum to somewhere around a 3-point harness. And this kid, they said, oh yeah, he was restrained. I learned my lesson that day. And from that point forward, I don't ask if they were restrained. I ask how they were restrained, because it would have given me a totally different picture of this child rather than the way I actually asked that question. The pearl that comes out of that is every person in the vehicle all sustained exactly the same amount of trauma. So all the occupants in a vehicle really deserve the same level of care. You don't bring one in on a hip and somebody else in on with a C-collar and long backboard. And then when returning a child safety seat after a motor vehicle crash, this was the other lesson I've learned over the years. Once the child has been involved, or a car seat has been involved in a motor vehicle crash, that car seat is no longer an option. It's no longer viable, and it's not guaranteed to secure the child. I actually picked up a kid one time. It was in a motor vehicle crash, and the straps on the child seat had been cut, which is what was our normal way of doing things. However, somebody had safety pinned them back together and sold it at a garage sale. So the way I do things now is when we have a kid come in with a safety seat like that after a motor vehicle crash, I take a chunk out of the child safety straps and remove them, because that way there's no way they can use that car seat again. People will do interesting things sometimes. Another little gal that we had, she was a 7-year-old female. She was a passenger in the back seat, and she was belted with a lap and shoulder harness, and she was in an SUV, and they ended up in a rear end collision. And I believe the story was from EMS that they were actually stopped at a stop sign, and they were hit from behind at about 45 miles per hour. So it was really a significant trauma that had taken place to the SUV. The child ended up that she actually slid underneath the way she was being secured, and she got hung up between the lap belt and the shoulder harness, which is really unusual to have something like that happen. Her original pediatric assessment triangle, her appearance looked normal, her breathing was normal, her circulation looked okay. And so we, as we started down the primary survey, it just didn't look like there was going to be too much that would go on with this particular child. Her airway is patent, her breathing was normal, circulation was normal with a cap refill of less than 2 seconds. She had a Glasgow of 15, and she had some bruising around her neck from the seatbelt and the way she was secured in the back. She was treated, and she with a C-collar and long backboard. She had oxygen rolling at 15 liters per non-rebreather. She had an IV of normal saline. They just opened it up at TKO because pretty much everything was within normal limits. Respiratory rate was 22, heart rate was 118, and her pressure was 90/62. Treatment on this particular kid when she got to the hospital was they did x-rays of the spine and neck, and they were all negative. CT didn't really show any spinal cord injury. She was admitted overnight for observation simply because all the other passengers in the vehicle, both the mom and the dad, were also admitted for some injuries. No urine was obtained on admission, and we usually traditionally do that with kiddos that have been involved in a motor vehicle crash, because we want to make sure that they're not spilling any blood into their urine. And so the nursing staff got the child up to go to the bathroom about 2 o'clock in the morning. She was unable to walk to the bathroom. They called the trauma surgeons right away. She had partial paralysis from her waist down. She'd lost sensation on the inner parts of her legs, as well as she'd lost sensation from the waist down to the leg. Interestingly enough, there really wasn't any evidence of injury when they did another set of x-rays thinking maybe there was something going on there. And they couldn't find anything. Um, Finally, after, I think it was about 4 or 5 days of hospitalization, she began to regain some sensation. And she actually was discharged home. She was walking with braces and a crutch, or in crutches. She still had lost some of the sensation that she originally had, which was unfortunate. And this is one of the other things about kids that you don't necessarily find out until it's almost too late, and it's called scoliosis. And that's where you have spinal cord injury without radiologic abnormality. What happens is because the kid's ligaments are so loose and they're so flexible that the spinal column can actually shift into the nervous system and into that the main nerve that goes down the body. Hers had shifted because of where she was belted at, and she ended up, it was almost like she was hung because of how she had slipped down and underneath the belt. And so it was it was really unusual. And again, you don't see this very often, but it happens on occasion. Had we not kept her overnight, we probably wouldn't have discovered her for hours later. As it was, they could give her some steroids and try and diminish some of the swelling that took place in order to salvage some of her nerve endings so that she would be able to walk a little better with maybe a little less traumatic trauma to the areas. The highest instances of this is in children under the age of 8 years, and they get this hyperextension forces, usually from rear end collisions or from a frontal impact. A lot of times those symptoms are delayed from hours in about 50% of these kids. And again, they get that cord compression and infringement onto the cord itself. And so you get that spinal cord injury. Again, kids can be restrained in different ways based on the vehicle. This happened to be an SUV. As many car seats as there are and as many vehicles as there are, it's no surprise that car seats don't necessarily get placed into cars in the appropriate manner that you would that is necessarily recommended. There are all kinds of different car seat safety things that go on. And a lot of the hospitals, when they traditionally discharged newborns, will help parents with car safety seats so that at least the original seat is put in correctly. But after that, it's kind of up to parents to figure it out. And it's not always easy when based on your cars and the child safety seats. Some of them have bases, some of them don't. And the actual class that you take is usually about 4 days long where you actually put car safety.
Reylon, we've lost your audio again.
Oh dear.
There we go.
You're back.
I'm back again.
Yep.
Okay. I apologize. I keep seeing my internet's unstable here for some reason, and I don't know what's causing that. This little guy was a 3-year-old. He was a fall victim with a reported head injury. And when we got there, we found the child was semi-conscious, pale, and restless.
Okay, again, yep, we've lost you again. I think. Okay.
Okay.
Reylon, maybe, yeah. Are you back?
Yeah. Can you hear me or no?
Yep, we got you.
Okay. He fell into the bushes, is what the mom stated. Our pediatric assessment triangle showed that the child was semi-conscious, his breathing was labored, and his circulation was quite pale. And when we did the primary survey, his airway is actually patent. His respiratory rate was 40, and it was slightly labored. We had breath sounds that were diminished on the right. He had a weak radial pulse. His heart rate was 140, His color was really pale. He was restless and he was moaning. The kiddo was just semi-conscious. He was moaning, so he wouldn't really answer any questions for us. He had some small scratches on the top of his head with no active bleeding. His chest expansion was symmetrical, but he had a large abrasion in ecchymotic area that was noted over the right lower rib cage and the upper right abdominal quadrant. And what had happened to this kid was he and his sibling were playing, and this little guy went through a third-story window out into a set of bushes. There were no bowel sounds present when we exposed him and listened, and he had extreme tenderness on palpation. Again, there were a few scratches just from the twigs that had hit him, but there really weren't any deformities noted on this kiddo. They placed oxygen, they put in a 22 gauge IV. His blood pressure almost immediately was bottomed out. It was 76 by Doppler. They were having a hard time hearing it. Heart rate then dropped to 76 and his respiratory rate dropped to 12. His respiratory efforts became increasingly labored. His level of consciousness deteriorated. He became unresponsive except to deep pain. His pupils were 6 millimeters bilaterally. The child respiratory arrested, and then almost immediately after that, cardiac arrested. On autopsy, they found a right hemopneumothorax. We had placed a chest tube, not we, I mean, the hospital had done that. He had 9 posterior rib fractures. He had a small left pneumothorax. There was air in the mediastinum, and he had a hemiperitoneum. The liver had actually torn away from the inferior vena cava. There was liver bruising, and there was air around the pancreas. So this kiddo took one heck of a hit in order to do some of that major damage. Type of injury seen in this CAPE study is simply blunt force trauma. Again, he didn't have any external things that would really indicate that he had anything major going on, but again, there was no external bleeding on this kid. Everything was bleeding internally. So he was bleeding into his lungs. He had an inferior vena cava issue. I mean, there were all kinds of things that had really messed this little guy up. The other thing that probably has been learned over the years, regardless of how good you are or how quickly you are there, some of these little nuggets will die in spite of your best efforts. It's a reality. It happens. Unfortunately, it happens all too often. And, it's not only the parents that are taking the hit, it's also the providers that are traumatized from the event as well. I always suggest, and will continue to suggest, that anybody that's involved in some kind of traumatic injury or death of a child, that you have an opportunity to do some critical incident stress debriefing with the staff and make sure that they have a chance to at least talk it out. We all think that we're really tough, and I know firefighters in particular think that nothing affects them, and that's just not the case. It does happen. And it happens all too often sometimes. So hopefully, you're not only taking care of the children that you're caring for, but that you're also taking care of the staff, because that's instrumental in keeping them on board and not losing them to burnout. This little individual was a 12-year-old. It was a bicycle accident, and what had happened was the child had hit a big pothole in the street, and he flipped over the top of the handlebars. He didn't have an helmet on, and there was a positive loss of consciousness according to bystanders, but we really didn't know how long he was out for. He seemed kind of dazed when he originally got to the emergency department. His breathing was labored and his circulation was quite pale. Primary survey showed a patent airway. Respirators were 26 and slightly labored, and breath sounds were equal bilaterally. His radial pulse was weak and at a rate of 120. He was pale, restless, and he was complaining of abdominal pain. When we took a look at him, again, his head had a small scratch on the right side of his face, but really no active bleeding. Chest expansion was symmetrical. Respiratory efforts continued to be labored, and he had a large abrasion and ecchymotic area noted over the right lower rib cage. Abdomen showed some tenderness on palpation. There were no bowel sounds. Extremities, really, weren't anything. There wasn't much more than a little bit of road rash, but there were really no deformities noted on this guy. EMS had placed oxygen. They had attained peripheral access. And when we got him into the emergency department, his blood pressure was now 66 by Doppler. Heart rate was 110 and his respiratory rate was 24. So we knew this kid was, he was now in hypotensive shock. So something was going on with him. As the time in the ER progressed, the child's level of consciousness remained the same. He was responsive. He became more responsive and oriented ×3, but his pupils were 5 millimeters bilaterally. What happened was the child ended up, he vomited and then he aspirated. He was taken to CAT scan at that point. He now had fluid and air noted in the abdominal cavity, and he was taken to the OR. Child had an exploratory laparotomy, and what had happened was the colon had torn away from the mesenteric artery, and that had caused fluid and air to leak into the abdominal cavity. Again, kids have a tendency to be very resilient. Once all that was repaired, that kiddo went home 4 days later, and within a week had returned to riding on his bike, even though he wasn't supposed to be. No surprises again. Blunt force trauma. Abdominal trauma is probably the third most common cause of pediatric deaths from trauma, and it is the most common unrecognized fatal injury that we have. Again, it's that whole idea of you can't necessarily see what's going on inside, and so they can have a lot of injury to the internal organs without necessarily having anything externally that you have anything to look at. So this is the other thing, kids, a lot of times, if you think about how they eat and their eating patterns, kids eat constantly. The little ones eat every few hours. The other pediatric pro with this is decreasing blood pressure. It's really a late sign in children. The first thing that kids do when they are victims of trauma or they have some internal bleeding going on, they'll begin to increase their heart rate because they're trying to oxygenate better. They do not have the ability to change their stroke volume. And so when they need to increase their cardiac output, the only thing that they can do is increase their heart rate. They have nice, young, strong hearts, and so they can't change that stroke volume at all. And so as a result of that, they'll start with increasing the heart rate. Once you hit the point in time when they're starting to decrease their blood pressure, that means that they probably lost between 40 and 50% of their blood volume because they are so good about vasoconstricting and shutting down areas that don't need blood supply for a while. And so once you hit that mark of the decreasing blood pressure, then you're in real trouble. You're going to have to make up a lot of time really fast. The way that you configure blood pressures in children is 70 plus 2 times the age in years. That will give you the minimum 5% baseline for a child. Anything less than that 5th percentile is hypotensive for that particular kid. Once they hit about 10 years old, 90 becomes the standard, just like it is with the adult population. This is about the last case study I think I have. This was a 9-year-old girl. She was sitting in a grain wagon. Interestingly enough, we're right in the middle right now of harvest season for the state of Iowa. We have a lot of farm injuries in this state simply because a lot of times the kids are either working or helping in the fields, and things happen. So anyway, this little gal was sitting on a grain wagon, and she actually happened to fall into the grain. Original assessment was she was alert and breathing normally, and her circulation was pink. Her airway is patent. She was breathing again normally. Circulation was normal. She was awake and alert. what had happened and what you're seeing here is this is an auger. So when she fell into that grain, her leg actually was sucked down into this piece of equipment that's known as an auger, and it wrapped itself around her leg and then it pierced up into her pelvis. The auger itself was acting as a tourniquet. And so every place that you see the curve of those blades there was pressing up against arteries and skin. The question really was for us, it was, how are we going to get this leg off of this auger? Because when she was transported in, EMS did exactly what they were supposed to do. And that was they left the impaled object on and they transported her with all of this equipment with it. The little brown items that you're seeing at the on the floor and a little bit around the auger is those are soybeans. So anyway, when we went to expose this child, again, we had the leg and the auger. She had oxygen on. She was had 2 IVs that had been established. They were both large bore. Heart rate was 88, respiratory rate was 22, her blood pressure was 102/68, which is normal for all of her vitals really were good. She had received some pain medication for what she had, what had taken place. We needed to remove that leg from the auger. Interestingly enough, we don't carry anything in the hospital that is made to cut anything quickly. All of the surgical things that we have are meant to be slow and methodical when you go to take off a bone or a leg or whatever it might be. We had nothing. We called maintenance to see what they had. They had nothing. What we ended up doing was calling the Des Moines Fire Department, which is where the hospital's located, and we asked them to bring the jaws of life. And in what you saw before, this is the holding room outside of the operating room. And anyway, the fire department came, they used the jaws to actually cut the leg off of the child. So she was anesthetized out in the holding area. We had all the surgeons there, everybody was ready to go. We actually removed her leg off of that auger using the jaws of life. She was then immediately run into surgery in order to cut off and clamp any arteries that might be bleeding. And there were a significant number that were because the pelvis is so highly vascularized. What you're seeing here now is the kind of the aftermath of what had actually taken place. So in the middle of the screen there is a foot. You can tell the blue and red behind that was actually a boot that she had on. And you can tell how that auger had just sliced into the skin. It actually, it didn't cut all the way through the bone, but it was close in a couple of points. More to the right-hand side of the screen is another portion of the leg that again had wrapped around, that the auger had wrapped around. And again, more pieces of the leg. I believe, where is it? Again, just different angles. Was something that frankly we had not run into previously. Most of the time when you have a child that ends up into an auger like that, a lot of times they lose their lives before anything else takes place. Yeah, there it is. When we piece the kind of the leg back together, you can see how the auger had just literally wrapped around it. And on the end that's to the furthest left on your screen is the head of the femur. So you can see where we literally had to take that whole leg off. She did survive this event. She was hospitalized for quite a time. Soybeans inherently, they will hold different kinds of funguses in them. And it happened to be a wet season that that they were harvesting in. And so there was all kinds of unusual things that were growing out of her wound, and she became septic at one point. So she was with us for a couple of months as we treated all the unusual fungi and basically tried to keep this kiddo alive. Just again, more pictures. this is the one time when you do see penetrating trauma. It was kind of hard to move your legs or your eyes off of that leg because it was just so encased in that auger itself. But, in order to save a life, sometimes you just have to think outside of the box. I would say this was probably one of the most unusual circumstances and one of the most crazy things that we had to have done in pediatrics in order to save the kid. She did end up being discharged. It was a couple of months later. They were not able to fit her with a prosthetic at the time because there was nothing to attach the prosthetic to. But she did learn to walk with 2 crutches and on her 1 leg. And last I heard, she was still doing quite well, and had she's out of college now. It's been quite some time ago, but is doing real well in society, even though that she went through something like that. The other thing to think about with kids is just don't do any more harm. Sometimes, you think about, well, what am I going to do with this child? And well, maybe I should do this or maybe I should do that. And it's sometimes hard to know exactly what is going to be the best for that particular kid that you're taking care of. Never be afraid to make a phone call and ask. If you don't have any idea whatsoever what to do with a kid like this, or if you just are just unfamiliar or uncertain, there's not an ER in the country that wouldn't be willing to take your call and help you with whatever you might need. And I always just say, reach out to those folks and do whatever it is that you need to do in order to get the kid the quality care that they deserve. And do you have any questions?
Chief, you talked about encouraging them to call in. I think that's important because when you find yourself in a field with something bizarre and you're not sure what to do, sometimes just a little guidance and reminders that you're doing the right things in bizarre situations. I don't think that's a bad thing to hit on even harder. Do you have any more thoughts or encouragements along those lines?
Well, when things are going right, don't try and do more than just right. I've seen kids that have come in that have been intubated and they're fighting the tube because they don't need the tube. Or it's been that the tube is way too small for that particular child because it's not that really anybody intended to do anything wrong. It's just simply was unfamiliar territory. We know in EMS that and I'll just talk about the state of Iowa, about 27% of the population in this state are kiddos. And yet only about 9% of the EMS runs are children. So that's a huge disparity in terms of why don't we see more kids in EMS? Well, the reason is they're just very mobile. You can pick them up and take them. And that's what a lot of parents do. I had, there's just been so many crazy instances all the way along, but I can remember squad calling in one time and they're like, this kid, we just don't know what to do with him. And then, it's like, well, just tell us what's going on. And so, if they're able to walk through the pediatric assessment triangle and then they can give us either a little bit of a history or at least some of that primary assessment, a lot of times the parents can just guide you to exactly what's going on just by giving the history. So if you can get a decent history from the parents, that's always going to be helpful for you. Children with special health care needs, I'll touch on them because they're always a little train wrecks kind of. And you really sometimes don't even know what to do with them. And they'll surprise you in terms of how long they're compensating or how they compensate for something. And then all of a sudden it's like, oh, well, I didn't know that kid could even do that. Because as you turn them around, they get better all of a sudden. So anyway, just getting the best history that you can from the parents a lot of times will guide you to probably what's going on with that particular kid.
I remember working in triage and also working with students as far as like those assessments on kids that you talk about that are so important, like how much trouble is this kid in? And a lot of times it's like if they're not terrified or protesting a little bit about your exam, they're probably sicker than you think, right?
Yeah, that's exactly right. If children are quiet, And, you know, if you get from like a 9-month-old on up to about a 5-year-old, anytime that those kids are quiet, you've got trouble on your hands. There's something probably pretty wrong. They may be very sick, or it's hard to know what goes on in their little minds. But if they're not up and around or fussing, those are the kids that I really worry about the most. If you start an IV on a kid and they don't just scream their lungs out, that's a problem. That's a kid that's got major issues going on. So frankly, the ones that are crying the most are the ones I like the best, because I know they're aerating, and that's a good thing. You know, respiratory season, and we're starting into that now. Respiratory is the #1 cause of issues in children. And you'll see a lot of it depending on the RSV season or whatever kind of season we might have. But a little bit of swelling in a little tiny airway leads to a lot of trouble, leads to a lot of difficulty breathing. The other thing along with that with children is kids under the age of 6 months they are obligatory, what we call obligatory nose breathers, which means that when their little noses get stuffed up, they don't know to breathe through their mouth. Adults know to breathe through their mouth, but kids do not at that age. So that's why you have to spend so much time sucking their little noses out. And once you do that, then they're pretty good for a little while.
I think Steve's got a
So-
couple of questions from the chat line for
A
you.
couple questions for you, Dr. Meeks. First one is, should you always suspect internal trauma or bleeding with children in an accident if no bleeding is present?
I would be highly suspicious, and that's where your vital signs come in. If they have that elevated heart rate, like I talked about, or if they're complaining of pain, or if they're exceedingly quiet based on their age, those are all big triggers for watch for internal bleeding. The other thing I consistently do is check that capillary refill. And if that's starting to be prolonged, if it's less than 2 seconds, you're probably golden for a little while. But if that's more than 2 seconds, you've already got trouble brewing on your hands.
Yep.
Of course, you have to take into consideration if you're in a cold climate and some of those kinds of things. But for the most part, that cap refill will really give you a lot of information.
Yeah, just as a reminder, again, you know, that adults, they have a tendency to compensate more on a curve, you know, when they're
Yes.
in trouble. Where children, they go along straight and then they drop off like a plateau. So when they
Yes.
decompensate very, very rapidly. So I think it's very, very important that you point out there that you constantly have to be taking those vital signs in there. You don't wait, you know, 15, 20 minutes or something like that. You need to constantly be monitoring that vital sign for trends and any changes in between there. And just to comment on capillary refills again, is capillary refill is better suited for the child than the adult. The adult, there's so many things to take into consideration there that can cause a delay in the capillary refill, but children don't have that. So that's good.
Yeah, that's correct. That's exactly right.
Yep.
And yes, they do compensate for a very long time, but then when they stop, they're done. That's it.
Right.
They're done.
Yeah,
Um,
that's where that's trying to. We always call it staying ahead of the curve.
That's exactly right.
Between there.
The other thing is when you do put kids on backboards or however you might immobilize them, be sure and watch that you're not putting straps over their belly and tightening them down. Children are belly breathers up until about the age of 8. And so if you tighten a strap down too tight, they won't be able to breathe because that's how they normally breathe. So just, you know, sometimes it's the things we do that we don't even realize we're doing that can cause the problem.
Right. Well, another thing too about putting them on a backboard, when you do that too with pediatrics too, you need to make sure, because their head is larger than the rest of their body in comparison, is you probably have to put some buttressing from their shoulders down to their pelvis area in order to maintain that neutral portion there. And then you have to raise it up. If not, you flex their head forward more in between there. So again, you know, you just kind of have to take into consideration the size of the pediatric head in comparison to the rest of the body. It's a little bit larger at all.
Yeah, it's a third of the size of the body itself. So when you think about that, I always think of it as a bowling ball on a stick.
Yes.
And so you got to raise that stick up in order to make it even, Steven, with that bowling ball.
Right. Now, we got another question here, and again, I can what's the best rationale for pediatric patients turning towards a vehicle versus adult turning away from a vehicle? pediatrics don't know the danger yet in between there. And it's like you see that with a lot of others. Where adults, they do know that. Kids are curious and they'll turn towards it. And one of the things that they'll do is they'll put their hands out when they see it. Where adults, they know what's, they have a reaction, they know what's going to happen. So they kind of turn away from the damage in between there. And that's why you see a big, you see a big difference in there. And you brought up another point about that I think is very important too, is the idea that the child-centered gravity is so much lower, that they do have a tendency to go down and under, where adults usually go up and over when they're impacted by a vehicle.
Yeah, that's exactly right. Kids just don't know. They turn into it because it surprises them, and so they're turning toward it to see what's coming. Where
Yep.
adults say, "Oh gosh, that's the car. I better turn. I need to run away from that sucker." Yeah.
Yeah. Well, very good. Again, I can't thank you enough for pediatrics. As you indicated, they make up between about 30% of the population, especially here in the state here and all. And I don't know, do you remember any statistics from blank, how many annual visits they have at blank? Blank is a children's hospital in Des Moines, for those of you that, and Reylon used to be associated with that quite a bit. And I just wanted to identify, how many how many times peds are seen in the emergency department where they might not necessarily be transported by an ambulance.
Yeah. Probably around 18,000 visits is what I'm kind of guessing.
Right.
I haven't checked on those statistics for a while, but there was a number. Interestingly enough, we don't intubate that much, even though we're a children's hospital. So, you just don't get the opportunity to do that a lot from the EMS perspective. So it's hard. It's very difficult to,
Right.
when you don't get to practice as much on children as what you do on the adult population. So you get very
Right.
comfortable with adults, and a lot of times not so much so with kids.
Yep. Yeah, I agree with you wholeheartedly. Well, Reylon, again, thank you